Hi, welcome to Diabetes Management and the Use of Technology. My name is Kelly, Kelly Marie Lynn, and I'm a registered nurse. I'm here today to talk to you about diabetes, prevention, and management. I'm a registered nurse, and today I'm going to talk about diabetes management and utilizing technology in today's world. Can be difficult to navigate. So we're going to take a look at some objectives for success in managing diabetes and explore avenues through technology. We're going to look at some objectives. When I talk to my students, I always tell them in the beginning of the class, let's look at the objectives. What do I want you to learn today? Well, today I'd like you to learn how to understand and explain diabetes type 1 and type 2. We're going to be able to describe the acute complications of diabetes and know the signs and symptoms of hypoglycemia and hyperglycemia. I want you to be able to explain self-monitoring of behavior changes and name the most accurate way of testing for diabetes. We're going to look at how to identify some commonly used diabetes medications and how to understand and access diabetes education virtually. We want you to be able to name 3 technologies which help with self-diabetes management at the end of this PowerPoint. So we're going to look at, what is diabetes? I like humor. I like to use humor with my students. This says, I try to eat healthy. I never sprinkle salt on ice cream, although some people may. I only eat decaffeinated pizza, and my beer is 100% fat-free. You know, as crazy as that is, our patients act like that sometimes. Sometimes we do, right? And we go to the doctor and we say silly things, and the doctor just kind of looks at us. But really, what is diabetes? Some people don't have any idea. So we're going to learn, first off, what is diabetes? Diabetes type 1. We're going to start with, as we looked at our objectives, we should follow our objectives. Diabetes type 1, the body does not produce insulin or pancreatic B cells. The immune system may have attacked the cells that make insulin. They're called human leukocyte antigens. There's a combination of factors that affect diabetes patients. They may be genetic, autoimmune, or environmental. Also, we have an idiopathic diabetes, which is, we're not really sure what happened. It could be strongly inherited, maybe not autoimmune. Often happens in Hispanics, African, American, and Asian ethnicities. There is a type 1 diabetes that is latent autoimmune diabetes. It happens in later life, but it is rare. So what do we look for in diabetes? What do we look for in our friends, our family, yourself? I'm not speaking to nursing students, so I'm not going to use as many medical terms. I'm speaking to the community. So type 1 diabetes manifestations, it's something we're going to see. We're going to be able to see this in a person. We call these the 3 Ps of diabetes. Polydipsia, it's an increase in thirst. They're very thirsty. Notice the patient's very thirsty, or your sister, whoever you're worried about. They're frequent urination, the second P, polyuria. And the third P, polyphagia, a rise in appetite. Really want to eat, very hungry. These are classic symptoms. We call them the 3 Ps, polyuria, frequent urination, polydipsia, excessive thirst, polyphagia, excessive hunger. Now, the person may experience, probably more than most, weight loss, weakness, fatigue, and they can become what we call ketoacidosis. At the average time a person is diagnosed with diabetes type 2, they may have had, or type 1, they may have had this for a while, but it's usually a very sudden onset when it finally comes on. You can go to the next. So we talk about acute complications. The reason we're giving this talk is because it's not it's not healthy. There are acute complications, and one could be diabetic ketoacidosis. We call this DKA, or HHS syndrome, hyperglycemia, and hypoglycemia. The hyper, as I tell my students, is it's too high. Hypo, it's too low. These are acute complications from having the disease of diabetes. An easy way to remember: hot and dry, sugar high. You're hot, you're really hot, and you're dry, sugar's high. Cold and clammy, need some candy. Cold and clammy, need some candy. And I know we have some diabetics here, and we also have family members who have diabetics or who have with some serious consequences. I know some people in here have had lifelong diabetic patients. I like this little comic. It says, "It's a syringe and insulin. Too bad. I had hoped that they would cure diabetes by now." Yeah, and so it's not a great disease, right? So, but we're going to we're going to talk about managing diabetes. Diabetic ketoacidosis, called DKA. This is one of the complications. It's characterized by high blood glucose over 240. The person will have ketones in their urine. This is a medical emergency. Acidosis, blood pH 7.3 or lower. So the person's gonna experience severe dehydration, excessive thirst, urination, sudden loss of weight, GI stomach problems, nausea, vomiting, blood pressure plummets, low blood pressure. Again, these are complications of diabetes. Orthostatic blood pressure, problems standing up, going to pass out, fall down. Tachycardia, real fast heart rate. Lethargic, can't arouse the patient or the person. They're going to have a fruity smell. Their sugar's real high. You're going to smell that real fruitiness. I remember years ago working in psychiatry and working up the psych floors, and many of our patients were diabetics, and you would walk into that room and you would have that sweet, sweet smell we'd smell in the room. We'd have to really get their sugars down. Also, a person with diabetic ketoacidosis, again, it's a medical emergency, they would have abnormal respirations. They're called Kussmaul respiration. They're rapid and deep. So it's real deep. I don't know if anyone's ever seen a child with these, but it's really scary. They're trying to clear the CO2. So managing diabetes is something that has to be done. You're diabetic, you're pre-diabetic, you need to learn about, and of course, we want to prevent coming to something like this. The next known is the HHS syndrome, hyperosmolar hyperglycemia syndrome. It's life-threatening. A lot of people can confuse this with the DK. It occurs with type 2 diabetes, typically in those over 60 years old. So the HHS usually has enough circulating insulin in the body, so ketoacidosis does not occur. Remember, it's a type 2, not type 1. There's fewer symptoms with the DKA. It's your sugar. The patient could become acidotic in over 240. This person, their sugar could be 500-600. Now, very severe. This is very severe also because you have these real high sugars. At the hospital, when we have a patient with real high sugars, we have to let the doctor know. There's a whole protocol because very severe neurological symptoms can occur. Most significant changes are in the blood composition, concentration in the blood, very high sugars. This patient will be difficult to awaken. They could have seizures. It could resemble a stroke. And so serum glucose is vital. It's a medical emergency. So you can see the serious complications and, how serious this can become. Again, we're here because we want to talk about how do we prevent it. If you're in pre-diabetic, what can you change in your life, etc. So the next one is type 2. We're going to go into the type 2 diabetes. We talked about the complications, and type 1 diabetes. I know it's a lot of information. Type 2 is non-insulin dependent diabetes, although the person could be have type 2 diabetes and eventually need insulin. All type 2 diabetes patients do not just take are non-insulin. They can become insulin dependent down the road. A chronic multi-system disease characterized by hyperglycemia related to abnormal insulin production, impaired insulin utilization, or both. It is the 7th leading cause of death. So it's chronic, it's multi-system. It affects every system in the body. It is characterized mainly by that high blood glucose in your blood. It's related to abnormal production and impaired utilization. So the car's not working quite like it should anymore. I'm always using cars with patients and health. I had told my husband yesterday, well, the cars are getting older. He knew what I was talking about. It was us. 7th leading cause of death. The body does not produce enough insulin, and or cells do not react properly to the insulin. I like this little cartoon. It says, I think diabetes is affecting my eyesight. I have trouble seeing the consequences of poor food choices. And that's a big problem with type 2 diabetics. They like to eat, right? And sure, I like to eat, and we all like to eat, but it's affecting our health. So we're going to go to the next one. Diabetes type 2 is the leading cause of adult blindness, end-stage renal disease, and non-traumatic lower limb amputations. Non-traumatic, not, from a motor vehicle accident. It is lower limb amputations. So it's very serious. Major contributing factor to heart disease and stroke. The body does not produce enough insulin, and the cells do not react properly to that insulin. Versus if you look back at type 1, when we were talking about type 1 does not produce insulin or the pancreatic B cells. This one is not, it still has insulin, maybe not enough is produced, and maybe the body's not utilizing it enough. So I love this cartoon. It says, you need strong medicine to relieve your stress. I'm prescribing a puppy. So all you out there, you have a lot of stress? I have our puppy friends. There's Mary over there with the puppies. She understands. We use our puppies. They're a blessing to us and us to them. But truly, animals are a blessing because they relieve stress. So I thought, I'm going to put that in there. You have stress, you walk your animal. You exercise. You walk a lot. You can walk with a dog. I have to take the dog out, and it ends up being a blessing to you. So the next one. Oh, you got it. Oh, this is a tough picture. I have so many. I was telling my husband today, I said, I have so many pictures of wounds. I didn't know which one to choose. Type 2 diabetes, complications. So you have a venous ulcer and a stasis. These are different types of ulcers. They're nonspecific and gradual. It is possible to have classic symptoms from the 3 Ps, and these complications come. Fatigue, recurrent infections, recurrent vaginal yeast or candida infections, prolonged wound healing, visual disturbances, cardiovascular disease, renal insufficiency. Really, type 2 diabetes, again, it affects all the systems of the body. So we want to prevent. If the person has it, we want to manage, and we want to improve lifestyle. So, I mean, if you look at, these are the types of, you know, not good healing. The healing properties, they're just not there. Prolonged wound healing. My granddaughter the other day had the cat scratched her on the neck, on the side of the face. So I, did everything and put a little bacitracin on it, and it was quite a scratch. She gets up next morning, it's almost gone. I laughed. I said, "Oh my goodness, that is amazing." You know what it is? She's young. She's young and healthy. Of someone, and she really was scratched. It's the freshest cat I had. This one goes, and she just went, shh, shh. Yeah. So I use that as an example. This is a really young child. She's healthy. She had two great somebody diabetic had gotten scratched like that, we'd be concerned, right? We're really going to have to make sure we take care of that. So, and it's already gone. So you have prolonged wound healing, visual disturbances, renal insufficiency affects the kidneys really bad. Tired, the person's tired a lot of recurrent infections. So we want to bring that blood level down. We want to bring that glucose down so we can improve their healing, so they have more energy. We don't want to have any more damage to their eyes. So we're going to go on to the next slide. So again, the complications from diabetes is high blood sugar, right? It's called hyperglycemia, which is high blood glucose, increased urination, increased appetite. So they have an appetite. It's kind of goes around a circle. You don't want to eat too much, but yet they want to eat more because they're sugar, and it causes them to want to eat more. Increased thirst. Low blood pressure could happen, fast heart rate, nausea, vomiting, extreme fatigue, lethargic. Again, we use that acronym, hot and dry, sugar high, need insulin, cold and clammy, need some candy. So that's what the blood sugar can do. So we're looking at causes of hyperglycemia. The patient or the person could have a great, be monitoring their sugar well, doing well, and then they become sick. That's going to put their sugar higher. So if you're diabetic and, you get COVID, right? You have some kind of virus or infection. Can you see how it's going to affect it? It's going to cause your sugar to go up. You see the comorbidities even with COVID, with the virus. The patient, it has the disease of diabetes. Now they in contact and they catch a virus, maybe COVID. Their sugar goes up and their healing properties go down. So it gives the virus, the COVID virus, a chance to get stronger. So you're really at a higher risk for not to do well. Causes of hyperglycemia: illness, infection. It's going to cause that sugar to go up, and your infection is going to it's just going to be harder to get over that virus or that infection. Corticosteroids. So a person, has asthma attack or whatever, they have a problem, or they need steroids for maybe a virus or something. They go and there's the problem again, somewhat with COVID. They put you on steroids, right? And you need the steroids or whatever the bacterial infection is or whatever's going on. The doctor gives you the steroids, but it's going to cause your sugar to go up even more because corticosteroids elevate sugar. Now you're already a diabetic. So you're finding you have all these added problems onto it. Too much food, obviously, overeating. Too little or no diabetes meds, non-compliant, stop taking the meds, right? Inactivity. So I used to work in rehab, physical rehab, and so the patients would come in and they were stable on their sugars, and they would start their first day of therapy, and I'd be like, no, 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 make sure they eat before they go, and because they were inactive. Then they go and they work out, they come back from therapy. It's the first time they had therapy in a while, come back from therapy, and their sugars they go into hypoglycemia too. So your activity, in this case, we're talking about hyperglycemia. So inactivity, not moving, makes the sugar goes up. So what do we want to do? We're going to want to be active. We want to move every day. Emotional, physical stress. You're upset. You have an argument with someone. You're under a lot of stress. It's going to cause your sugars to go up. Someone dies in the family. You have something that's upsetting you. It's going to cause your sugars to go up. It's going to put you at higher risk. We always ask, what are the risk factors? What's going on in the person's life? All of those things are causes of hyperglycemia. Not the diabetes itself, but it will throw your sugars off. So you have to be really savvy and get a lot of education, on this. Poor absorption of insulin, of course. And now we're going to talk about low blood sugar. I always tell my students hyper high, hypo low, right? Glycemic sugar. Blood glucose less than 65 is considered hypoglycemia. The person will feel cold, clammy skin, headache, hungry, sweaty, shaky. They have that clammy look. You can just see that clammy look. Numbness of fingers, toes, and mouth, hungry, maybe some heart palpitations, sweaty, shaky, irritable, difficulty thinking, dizziness, fatigue, sleepiness, slurred speech, weakness, lack of coordination, and seizures. I have 2 cases that I remember very vividly. I always use I use all the bad cases with my students. I never remember the good ones. Years ago, before I was a nurse, I remember my old pastor, he had a good friend that he used to work out with in the morning. And one morning he didn't show up at the church. And so they were all looking for him. And by 4 o'clock that afternoon, he was on the news. He had driven into the Hudson River. His sugar was 20-something. I don't know when they found him. I don't even know how they knew that number. That's what I heard. Anyways, that was what happened. He had given himself too much insulin, and he dropped. So too much insulin. He was we call it a brittle diabetic, type 1. He drove himself into the river, and he died. The other story I remember very vividly, and I was instrumental in actually helping this person, was I was working somewhere, and I remember they were rushing me to go into a meeting. And I had a little attitude, and I said, I'm not going in yet. I just saw that lady, and I have to go look at her again. They said, she's fine. And it was a PCA and someone else, another nurse. And I said, I don't know. She just didn't look right. So I said, I'll be in a minute. And, I'm notoriously late. My husband knows that. So I said, whatever. I'm going to be a few minutes late. And I went down the hall, and I went in, peeked in the room, and she was sitting in her chair. And I looked, and I automatically called a rapid response. She was all, tightened up and contracted. We took her sugar, it was like 20, and we gave her shots, glucose shots, and she came right out of it. By the end of the day, I remember seeing her, she was talking just like us and looking just like us and totally fine, and I remember thinking the meeting was an hour. She would have died. So, or she, wouldn't have been good. So hypoglycemia is a very serious thing, just as much as hyper. One of the doctors I worked with, I remember him telling me, I remember all the little tricks he would tell me, and one was, Kelly, they can live high for a while. I'm not worried, not that he wasn't worried, but he said, they can live high. The long-term consequences will get them. They can't live low here. They will die right away. I never forgot that. So I always made sure when I put the food in front of them, they were going to eat. I made sure people took their first bite of food. I was always cognizant of that. Not that we never had problems, but they were very few. Causes of hypoglycemia, and I just spoke about some of these. I like this picture. Factors that can cause hypoglycemia in people with diabetes, because it's very serious, right? The long-term high, you're going to have those complications. You can end up with neurological defects. You can end up with DKA. You can be in the hospital. It can cardiovascular. Yes, there's complications, but they're long-term, and you'll see them over time. So we have time to change them maybe and manage them. Person sugar drops, there's not much time. All right, this is an immediate thing. So we need to speak and teach people about hypoglycemia. Factors that can cause hypoglycemia: incorrect dosage of medication or insulin. I know it's not around here, but there's a hospital and system in Amsterdam and in that up there, up north. They only allow 2 nurses to give insulin. You have to have 2 RNs, not even an LPN, in another system. I know the system. And I don't think it's a bad idea. Incorrect dosage of medication or insulin can kill somebody. Exercise more than usual. So they started therapy, the people I know, the patients. They hadn't been moving a lot. They're on the same medication, and all of a sudden their blood glucose drops because now they're exercising. Exercise is good, but you have to know how to maintain that if you're a diabetic and you're taking insulin. More than usual or without eating or with delayed meals can. So someone says, oh yeah, I'm going to eat. They take their insulin, and then they get a phone call and somebody upsets them, or I don't know, maybe they want to watch a TV show. Somebody comes to the door and they eat 2 pieces. Now they just gave themselves all that insulin. They forget. Guess what can happen? Right? And that is a big problem. What if there's no one there? All right? So too little food, delayed, omitted, inadequate intake. Not taking medication or insulin regularly, delaying or skipping the meals, and lack of carbs. Too much diabetes medication, too much exercise, diabetes meds or food taken at wrong time, loss of weight without change in meds. That's a big problem. That's why we really need to utilize more technology with patients, so you can get a hold of your doctor, talk to him. Even seasonal changes. People eat different as the seasons change. Use of adrenergic blockers, B blockers, interfering with recognition of symptoms like beta blockers. Medication. So we talk about what can we do to change risks. Maybe you are diabetic. Maybe you are a diabetic. Maybe you're not. But there are, we call these non-modifiable risks. These are things we cannot change. We can't change. We can't change our family history of diabetes. We can't change our age. We can't change our race or ethnicity. And we can't change a history of gestational diabetes. By the way, I had gestational diabetes for 2 of my children, and then I didn't have it for the younger children. But that tells us that something's could happen. It could take a change. So we can't really change those. We can't change that, I had a close relative die of kidney disease. We can't change that. Can't change the age. You can't change what is in your race or ethnicity. But we can modify other things. And we're going to look at that in the next slide. We call these modifiable risks. These are the things we can change. We can change our activity level. We can change our body fat or body weight, right? I'm trying to eat salads, and I love to eat, and I love junk. I have to admit, I do, but I'm working on it. Last 3 days, I had salads every day, lots of salads. We can change. We can bring our blood pressure down by healthy living and exercise and eating right, less salt. We can bring our cholesterol down somewhat by not eating so much, the things that cause all that. So these are modifiable risks. These are things we can change. And I myself am trying to work on that. And how do I manage diabetes? Well, we looked up here. We manage diabetes by diabetes is a chronic disease that requires daily decisions about food intake, blood glucose monitoring, medication, and exercise. It's okay. Oh, I don't know if you can do that. Can you? Great. Patient teaching, which enables the patient to become the most, or patient, person to person, community member to community member, which enables the patient to become the most active participant in his or her own care. It's essential for a successful treatment plan. Nutritional therapy, drug therapy, exercise, self-monitoring of the blood glucose. These are the tools that we use in the management of diabetes. And healthy diabetes plates. Healthy diabetes plate. For some people with type 2 diabetes, a healthy eating plan, regular physical activity, and maintenance of a healthy body weight are sufficient to attain an optimal level of blood glucose levels. So I've taken a lot of this information from healthypeople.org, and that's it for that. We can go to the next one. So what do? We start with a goal. So say you're a diabetic or you're pre-diabetic. You don't want to become a diabetic. You're diabetes type 1. You want to become more educated. You want to change the outcome of your life. And so we start with a goal. Goals of diabetes management. One goal, maintain the blood glucose level as near to normal as possible. So we check our blood glucose level. We want to decrease the symptoms. We want to promote well-being. We want to prevent those acute complications that we were talking about. We want to prevent the ulcers and the skin problems, cardiac problems. We want to delay any onset and progression of long-term complications. And we can do that with lifestyle changes. I saw this. I said, I have to put this because he looks very determined and kind of smug in his own way. And I could just see him looking at me and saying, you need to lose weight. Anyone with type 2 diabetes needs to lose weight even if they have a normal BMI. Yeah. So, it's probably going to put a lot of us in that category, right? I don't have a normal BMI. I'm a little over. So don't feel bad. We're all in this together. What does 20 grams of carbs look like? So I saw this and I said, I have to put this because you can move that. I think you can move that over. It says, the first one is 4-ounce baked fish. It's really the size of your hand. It's not that very. I see someone shaking their head. They know. 4-ounce baked fish with mushroom butter sauce, 0 carbs. 1/2 cup barley cooked with turmeric for color. It's 22-gram carb. And 1/2 cup roasted carrots or no carbs. It's an excellent meal. I got a lot of these recipes from easyhealthhealthyliving.com. They have 20 carb meals. I have the next one is a roasted pork tenderloin, 5 ounces So again, small. Half cup cream spinach, 0 carbs. Half cup sweet potato. So that's 20 grams. The asparagus, baked chicken, almond flour coating, 3 ounce, 3 grams carb, skillet, sweet potatoes. Now, the good thing about my daughter cooks like this. I know, right? It does make you hungry. This one is my favorite. I have salmon a lot. Sweet salmon, roasted squash. Love my roasted squash. And easy mushrooms. That is 20 grams. So 20 grams of carb. These are great recipes. You can look them up. I will tell you, they get fun. I have a child, who's not a child anymore, my youngest, who has she has an autoimmune problem. So it's not diabetes, but she eats like this. And it's so fun to eat with her because all her meals look like this. She has her friends over a lot and they bring things or I'll have stuff and we'll kind of get together and I have to really learn to eat more like she does. So the next one I'm looking at is why monitor blood glucose? Monitor your blood glucose level for too much glucose or too little glucose. And it shows you that's a little monitor and they prick their finger. Sometimes some people have to do this 3 times a day, more, 4 times. Depends. You have to follow the doctor's orders. So self-monitoring of blood glucose. Well, we need to learn how to use the machine and when to test. Everyone is different. So you may meet someone who says, I only test in the morning. Or I test morning and night. Well, someone else says I test morning, noon, night, and or evening dinners, all meals, and before I go to bed, right? But when to test? Before meals, 2 hours after meals, always when a hypoglycemia is suspected. Remember that real low blood sugar. So I can only tell you the times that I would go to the doctor and I'd say something's wrong with my patient. And the first thing he'd say out of his mouth is, did you check the sugar? And I'd say, oh, no, I got to do that. But they're not a diabetic. I don't care. And so I'd run and do that. And, that's the first thing that always comes to you. Did you check their sugar? Before, during, and after exercise, because things could vary, right? So just because you don't take your mother or your grandmother out much and all of a sudden you take her for a walk and you have a great day and and she's going to have that 15 units and she's been exercising, it's going to throw everything off. So it could be before, during, and after exercise. Even if she's not normally, you might want to talk about that with your relative. Any time for increased frequency, it has to be done. Initiation of a therapy or actively adjusting a therapy, you're bringing something on new. Something is changing. They're giving a new medication. Can throw a lot of things off. Fasting, low blood glucose occurs after a meal too. So that's a whole nother. So if they have signs and symptoms, you think, oh no, they just ate. It can't be. It can be. You have to check. Don't be afraid to check. Now we're going to talk about testing. So if you have never had an A1C test or an HbA1c test, this is a blood test that measures sugar levels in the blood to diagnose and manage type 1 and type 2 diabetes. It measures the average blood sugar levels over the span of the last 2 to 3 months by measuring the percentage of hemoglobin proteins that are coated with sugar. It's called glycated. So they can look back and see what has your sugar been for the last 2 to 3 months. A baseline A1C test should be performed for all adults over 45 years old. When screening for diabetes, a normal A1C level is below 5.7. Pre-diabetes is between 5.7 and 6.4. And diabetes is definitely diagnosed at 6.5 and higher. I've seen patients come in And I kind of was like shocked. I'm like, did the doctor see that? Yeah, they're all aware, Kel, don't worry. It's like 13, 14. I've seen those numbers. Um, Very complicated cases. They've been sick for a long time. Next one. So, types of insulin. Typically, type 1, I said this earlier, typically type 1 start on insulin because their pancreas is not producing. But that doesn't mean type 2 diabetics do not eventually have to go on some kind of insulin. There's different types of insulin. They're not all the same. So they have the rapid insulin. You inject it and 10 to 15 minutes before meals. This is your Humalog. It's right up here. It says rapid or Lispro. Typically used with longer acting insulin. Then you have your short acting, which is inject at least 20 to 30 minutes before mealtime. When I worked at the hospital, I made sure, because we didn't know, sometimes those meals would get messed up or someone's meal wouldn't get brought up. I learned. I made sure I saw the tray, and the tray is at their door, and they're ready to have it, and it was theirs. I was very careful of that because I didn't want to see that hypoglycemia. We have to do that same thing with us because of all the things we just had spoken about. The intermediate is commonly used twice daily. That's NPH. Lenti, that's an older one. And then long-acting, Lantus, Glargine, Levemir, they cover insulin needs for like 24 hours. Often they're given once a day. And then we have pre-mixed insulins. Individual patient responses to each of these insulins are different and affected by many different factors. And the next one. I'm not going to go through and talk about it, just want to mention this, just so you're aware. Because if you just became a diabetic or you just were diagnosed with diabetes, you say, well, why? I don't understand. I heard about insulin in a vial. I heard about pens. I hear about pill form. I don't understand. The picture's very big. So insulin can be drawn up through a vial. These are vials. We do those in the hospital, but they could be, at homes. Older people have done this before on their own. Insulin can be drawn up and given through a pen, syringe, and through a pump. Generally, you see them at home in a pen form. Some people have pumps, but they're various. These are all different ways that insulin can be given. And so, okay, do I have diabetes? Well, as the comic says, another new iPhone is out, and I'm still waiting for an upgraded pancreas. It'd be nice to upgrade our pancreas, right? It would be great. We're up to, what are we up on those iPhones? Like, is it 11? Crazy, right? I think they do everything. They talk to you, that you're talking in the room, they answer the question. Be nice if we could save some pancreas, right? But anyways, we're gonna look at a case study. So, this is Sam. Sam is right here. He has a briefcase. Sam is a 55-year-old African-American male who works as an accountant. He presents to his yearly physical appointment at his primary physician's office. His blood pressure is 159/86. His heart rate is 90. Respirations are 20. He's gained 14 pounds since last year. He states he has some numbness in both of his feet. So the doctor says, how are you feeling? I don't know. Good, Yeah. You haven't noticed anything unusual? Yeah, I get this numbness in my feet sometimes. He states he's noticed an increase. I've been thirsty a lot, just tired. Man, urinating a lot at night. It must be getting older. I have to get up every night. The doctor does a full medical exam. He notices that he has somewhat of a scaly-like rash in the inguinal areas and under his axillae. So he's got some things going on. Sam says, I've had this rash on and off for 2 years. Really? Yeah, it gets worse when the weather's hot. So we look at Sam. There's Kate. What he's got some risk factors. What risk factors for diabetes does he have? Does anybody have any idea? Risk factor? So age is a risk factor. It's okay. It's okay. So think about those things that we talked about: non-modifiable and modifiable. Age, race, ethnicity, very good. Family history. So what does he have? He's a 55-year-old African American male, works as an accountant. He's got some risk factors for diabetes here. Just by looking at that, what do you think? What do you think is his? That's right. And his blood pressure, right? Yeah. Oh, and also he gained weight, right? I mean, he's overweight because obesity could be, I mean, he's not obese yet. It doesn't say his age. It just says he gained. That's a lot, a year. Yeah, it's a lot. So his risk factors, and which type of diabetes is at the highest risk for developing for him? What do you think? That's correct. What clinical manifestations of diabetes is he? Yeah, no, good. What clinical manifestations of diabetes is he displaying? Yes, 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 yes. Excellent. Yes. Clinical would probably be the thirst and the urinating a lot, and the feet. What diagnostic tests for diabetes would you expect the healthcare provider to order? We learned about it. What's it called? You got it. A1C. Excellent. Yes. So he has these tests, and his glucose test comes back at 253. His A1C is 9.1, right? So if we look back at the A1C test, it says diabetes at a level of 6.5 or higher is diagnosed. So he's now, he's 9.1, right? His urine is positive for glucose, negative for protein. His rash is a yeast infection. That happens a lot with diabetics, right? And they've done an HCG, and he's got some heart problems going on. So we have to get him taken care of right away. It's already affected his heart, so he's been sick for a while. Case study: Sam receives a diagnosis of type 2 diabetes. So what treatments do we expect Sam to receive? What do you think the doctor is going to do? This could be any of us. Absolutely. We're going to work on that. What is it? Yes. Yes. So, the next one? That was good that you left it there. You got it. Oh, there are. And they have a hard time. I have a hard time saying them. Case study: goals of diabetes management, just what you said. We want to decrease the symptoms. We want to promote well-being. We want to prevent acute complications. Delay any onset and progression of long-term complications. So we want to delay and prevent. Delay, and I was talking to my professor, and she said, prevent, use the word prevent. Prevent, delay. That's what we want to do to save lives. So case study: goals of diabetes management. Sam realizes that he needs to start exercising in order to gain his health back. He asks you what he should be doing. He's got a vision. That's like me. I have a vision until I look in the mirror. I see my daughter, who's an exercise queen. Actually, she teaches people. So she's all muscles. And then I look at me. It's a good look. Well, anyways, it's a good goal. So Sam realizes that he needs to start exercising in order to gain his health back. He asks you what he should be doing. Okay. Yeah, right. Case study, goals of diabetes management. Sam's healthcare provider orders, there you go. One of you said he's going to order a medication. He's going to order metformin, 500 milligrams by mouth twice a day. And we're going to talk about the mechanism of action and what you would teach, what I'm going to teach him. So he's going to go on he's a first line medication for diabetes type 2. He's going to take it twice a day. Okay? We're going to jump ahead 6 months because patients are at risk, or people are at risk, type 2 diabetics, just because they're doing well, they're taking their meds. We think they are. We think everything's okay. Things can change. They might need a medication adjustment. Maybe they're not compliant. Who knows? Case study, trip to the ER. 6 months later, Sam presents at the emergency department. He's accompanied by his daughter, who states that he recently was treated for a pneumonia. She feels that he hasn't been right since. Remember what happens when you have diabetes. You have diabetes, you get an infection, now it throws everything off. What has just happened? Now the person's more at risk. They're not back to their baseline. So she feels that he hasn't been acting like himself. She notes that Sam has been complaining of fatigue and has been irritable. She cannot confirm whether he's taken his diabetic medications. She is now concerned because she thinks he might have had a stroke because he's not right. What should she be concerned about? Okay, so they admit him. Sam's admitting blood glucose is 832. He is admitted to the ICU for IV hydration and insulin therapy. Sam receives IV therapy, and he does very well. They have to slowly bring down the glucose. After slowly bringing Sam's blood glucose level back to normal, he is able to maintain his blood glucose in normal range with metformin only. He is discharged home, so they do a trial. What they do in the ICU, they bring it down, they go to the med-surg floor, he's okay, and they trial him back on as he's doing well. They send him home. He is discharged home and instructed to follow up with his regular physician in the next 2 weeks. Sam now states he understands the need to take his medications and to monitor his blood glucose as ordered. Sam's wife, Susan, becomes his co-partner in his health care. So his wife really gets involved now. She says, I got to get involved in this. Case study, Sam's health improves over the next year. Sam loses 10 pounds, and he reports all area of his life are improving. His relationships are improving because his blood glucose is better. He's not as irritable. He's not tired. He feels good. He's getting exercise. He's eating right. Sam and Susan take weekly hikes and have grown fond of cooking meals together. Positive outcome. Something about this, I've known people, who've had this in their family, and so one person does well and the other one doesn't have the problem. And when you have a diabetic, you want to make it a family thing because it's not fair to pull out big things of ice cream and eat in front of them. We need to encourage them. And so she, as you can see, she says, they take hikes together, they start cooking meals together, and cooking does bond people. So now the relationships are better, and they're growing together. So I thought this was an excellent outcome. Now, we haven't touched on yet, remember yeah, no, you're good. If we go back can we go back to our objectives quickly? And it's all the way to the third slide. If you look back at the objectives, when I tell people when you're learning a new subject, keep going back to your objectives because this will help you to remember, what am I supposed to get out of this? So we've gotten to be able to explain the self-monitoring, name the most accurate way of testing for diabetes, being able to identify some commonly used diabetes medications. That's where we are. So I'm going to go down and I'm going to tell you all about some medications. Mechanism and the mechanism of action. The first line, which Sam, the doctor, prescribed, was metformin. This is a first-line medication, treatment for diabetes type 2. It decreases glucose production in the liver. It increases insulin sensitivity. It improves glucose transport into the cells, and it may cause weight loss, which is nice. So if you are a diabetic and you go on this, you may be able to lose some of that weight, right? Including lifestyle. We have what we call sulfonylureas. These are your glyburide. These are first-line oral hypoglycemic drugs available first and second generation. They act by stimulating the release of insulin from the pancreatic islet cells. They increase the sensitivity of insulin receptors on target cells. The side effects of these meds, some of you may know these, are hypoglycemia. They may require dextrose to return glucose to normal. So these aren't going to be the first drugs they're going to use. The Starlix and the Prandin, these stimulate the release of insulin from the pancreas cells. Again, that's only short action, 2 to 4 hours. These medications are well tolerated. Hypoglycemia is the most common side effects. And then the alpha glucosidase inhibitors, this is like Glycet, Miglitol. They block enzymes in the small intestines. They're called starch blockers. Some of you may be familiar with those. They slow the breakdown and absorption of sugars and starches. Now, the interesting thing about the side effects for these, garlic and ginseng may increase a hyperglycemic action. So if you are taking these meds and you're taking garlic and ginseng with it, it's actually could, like together, like you put garlic and ginseng in a, it actually will drop your sugar more. So when you're taking one of these meds, some of these meds, read the side effects and know the possibilities, because some of the food can make a difference. Also, side effects with these: diarrhea, cramping, liver function should be monitored. And if they do become hypoglycemic from these drugs, they have to be treated with glucose. So you have to have the glucose shot home because they actually inhibit the absorption of sucrose, which is table sugar. The other ones are incretin enhancers. Those are Tradenta, Januvia. They block the inactivation of incretin hormones. What does that mean in lay terms? They increase insulin release. They decrease glucagon secretion. And there are some side effects: pancreatitis, allergic reactions to those meds. The glucagon-like peptide receptors, I know them as Byetta and Trulicity. I know some of you are on those meds. They lower the glucose levels by slowing glucose absorption from the intestine. They increase insulin secretion when blood glucose levels are high. They stimulate insulin secretion and lower glucagon secretion from the liver. They slow stomach emptying. Byetta is given twice daily. Trulicity is only given once a week. The side effects are nausea, vomiting, diarrhea, and nervousness. And I know you're on those, right? Some of those, yes. So now we're going to talk about technology. What technology is best for managing diabetes? Well, you need to have a glucometer. All right. The most important device for someone with diabetes to have is a glucometer. A finger stick will give your blood sugar, will give you the blood sugar level. Your little finger stick, we talked about that 3-4 times a day. Some people are once. Even if you use a continuous glucose monitoring system, you'll still need to occasionally use a meter. And I have up here insulin pens and the pumps. So it's just some pictures for you to look at. Patient monitoring, chronic patient monitoring for diabetes. They have something out now that's called remote patient monitoring for diabetes. A physician can quickly be notified if your blood sugar is level. So they have remote monitoring. The doctor's office, your physician's office, clinic will know about what's going on, and someone monitors you. Technology, they have something called Dexcoms, continuous glucose monitoring. It's a system that's equipped with alerts that can warn you of approaching low levels. It does night monitoring. That's a problem. People wake up in the morning with low blood sugar. That does night monitoring. It'll wake you up. I really like this. This is called Freestyle Libra Zap. This is, if you can see the lady up on the right, she is opening the package. And what it is, they put a little pinprick into your arm, and then you attach a little disc. And for 14 days, all you have to do is scan it. I liked the idea of this because I worked with a lot with diabetics, and their fingers, 3, 4 times a day, their hands, they're shot. So they only have to do it once every 2 weeks. They have the little scanner and they scan. So I can see where this would really be a blessing to someone. You check the glucose with a painless scan instead of finger sticks. And you apply the sensor in the back of your upper arm. The sensor has a thin filament that is painlessly inserted just under the skin. You do it yourself. You use the handheld reader. And Medicare covers this. So this is something you might want to look into. What apps are available? I gave you a little handout. So and it's just a reminder, but in your handout, I put some of these apps that you can track your blood sugar levels, show trends, monitor your diet, log your exercise, provide a peer support community. Resources, give access to highly trained diabetes educators, fitness coaches. There's a list of apps called My Fitness Pal. You can enter your own recipes, track how many carbs you're eating in a day, log your exercise. The app Lose It offers similar capabilities. LibraLink, Glucose Zone, Diabetes M, and My Sugar. And a lot of people like My Sugar. They offer a comprehensive approach to diabetes management. That's how they say it. Home telemedicine. So let me just tell you a little bit about that because I wanted to touch on more of technology. I talked to you about some of these. There's been some positive outcomes. So home telemedicine for those persons in their early 20s and who live with diabetes reported positive outcomes. They enrolled in an interventional program. It was like a trial. We're hearing a lot about trials right now on TV and evidence-based practice. They enrolled in this trial, interventional program, and they had to attend 3 telemedicine visits. The patients completed questionnaires, measured distress, self-efficacy, self-management, and depressive symptoms. At the end, the patients were able to connect through virtual technology from any location, and they reported that their mental health and their compliance, adherence with diabetes self-care was the best that it had been. So it was a positive outcome. So what they're saying is this home telemedicine, speaking to the doctor, nurse educator, having a support system does make a difference. People need this. So I wanted to include that. Now, I did want to include limitations. There are limitations to all of these studies, and we talk a lot about limitations. Health interventions became difficult to manage along with the chronic illness. So you have a chronic illness, and now I'm giving you all this stuff to do. And what happens, people get tired of that. And they say, you know what, I'm tired of dieting. I'm tired of doing this. So there is some limitations to these. Nutrition diaries and planning can contribute to a substantial time and energy expenditure. Can take time. It's time to be organized. It can contribute to the burden of disease. And it's a challenge of applying interventions to balance support without adding a burden to the patient's life. So what I say as a nurse, I would give my patients little steps. If I was working in the community, I would work with them little by little. I don't say all at once, you better shape up. You better lose weight, you better be exercising, are you doing your 20 carbs? So yes, you have to do things in small steps. And for family members, you want to do things in small steps. We don't want to overwhelm our family members, right? Because it's going to be too much of a burden. And so I'd like to give thanks to my preceptor, Dr. Tammy Nutter, for her wise instruction and encouragement. I'd like to also thank my husband and friends for their assistance with the camera and the computer setup, for coming out here, for watching me on YouTube. Thank you so much, and many blessings to each of you. I really appreciate you coming so I could work on my program, and I'm finishing my master's soon. I've given you a little handout, Diabetes Management, and it talks about goals, recommendations, carbohydrates. It's not the PowerPoint. These are things you have to look up, and they're reminders. I also put in your handout choosemyplate.gov. You can go on there, you can start an account, you can monitor your food, your diet. I think it's one of the best out there. And on the back, we have all about being a diabetic. I also have asked if you wouldn't mind, and if you want to email it, scan it to us, or fill it out. If you're watching by YouTube, if you could email it to us, we've already given you the email address. And for those people who are here, if you could fill one out and leave it in the back as you leave. This is a survey. It says, thank you for attending the lecture, Diabetes Management and Technology. Thank you for answering the following questions. This survey will help us in the future as we reach out to our community. And you don't have to put your name on this. Please be honest. And again, I thank you, thank my Dr. Tammy Nutter, and all those who assisted. Thank you. Thank you for coming. Thank you so much for coming and listening to me. Oh my gosh. You had to listen to all that. Oh, we were going to take questions, but you know what? We'll take them. Jerry, that was long, wasn't it? Yeah, okay. Oh, yeah, it's perfect that I'm not on for the questions. Yes.